Hello, everyone. This is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us for tonight's webinar on hepatorenal syndrome, known as HRS. Liver Health Foundation is a California-based 501c3 patient advocacy nonprofit. Many of the members of our board of directors represent liver patients and caregivers. Liver Health Foundation's Medical Advisory Council, led by Dr. Sami Saab from UCLA, has over 50 members who are some of the best hepatologists and liver specialists in the United States. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host community and patient-centered free educational programs. As you know, today, February 29th, is Rare Disease Day. There are over 300 million people worldwide who are living with a rare disease. Despite the name rare, between 3.5 to 5.9% of the population is affected by a form of liver disease. Due to their nature, there is a lack of research, which delays diagnosis and impacts the treatment options available. In recognition of Rare Disease Day, we are offering tonight's webinar to raise awareness of HRS, which is a rare disease of kidney and liver with important consequences. To learn more about our upcoming webinar and in-person events, please visit our website, liverhealthfoundations.org. Tonight's program has been made possible by a grant from Mallinckrodt Pharmaceuticals. We thank Mallinckrodt for their support of our efforts and hope you find the information helpful. I would like to acknowledge Ms. Holly Kirkpatrick, who is the acute care business manager at Mallinckrodt. Holly is a familiar face to our audience. Thank you, Holly, for your support. Now, Ms. Jennifer Terrell, the Regional Business Manager West for the Hospital Acute Care Team at Mallinckrodt Pharmaceuticals, will tell us a bit more about Mallinckrodt. Ms. Terrell, we are ready for you.
Okay, thank you so much, Farah, for inviting Mallinckrodt Pharmaceuticals to sponsor this evening. We appreciate your leadership, advocacy, and education towards greater liver health in California and throughout the Western United States. As you mentioned, I am Jen Terrell. I'm the Regional Business Director of the Western United States for Mallinckrodt Pharmaceuticals. I'd like to also thank Holly, who is the Acute Care Business Manager of the academic centers and hospitals in Los Angeles and Hawaii, for helping to put this program together and work so closely with you. Mallinckrodt Pharmaceuticals is a global business consisting of multiple wholly owned subsidiaries that develop, manufacture, market, and distribute specialty pharmaceutical products and therapies. The company's specialty brands, reportable segment areas of focus include autoimmune, rare diseases, and specialty areas like hepatology, neurology, rheumatology, nephrology, pulmonology, ophthalmology, and oncology. It is also we have a specialty generics reportable segment that includes specialty generic drugs. We just want to thank you, Farah, for this opportunity. We really do fully believe that it's an important educational evening on HRS for the Rare Disease Day. So thank you so much.
You're very welcome. Thank you, Ms. Terrell. Thank you, Ms. Kirkpatrick, and thank you, Mallinckrodt. We appreciate your support. It is now my pleasure to introduce Dr. Alexander Ko, who has generously agreed to be the presenter in tonight's webinar. Dr. Ko, MD, FAA, SLD, is Professor of Medicine at Cedars-Sinai Medical Center and HS Clinical Professor of Medicine at UCLA. He is the medical director of the Liver Transplant Program and the program director of the Transplant Hepatology Fellowship at Cedars-Sinai. Dr. Ko earned his BA in biology from Johns Hopkins University. He received his MD degree from the University of California, San Francisco, and completed his internal medicine residency training at Massachusetts General Hospital before returning to UCSF for his fellowship training in gastroenterology and hepatology. He is double board certified in gastroenterology and transplant hepatology. His clinical and research interests focus on liver transplant outcomes, viral hepatitis, and complication of cirrhosis. He is the principal investigator in numerous clinical trials involving alcoholic hepatitis, acute and chronic liver failure, portal hypertension. Dr. Ko is a fellow of the American Association for the Study of Liver Disease and serves on the AASLD Training and Workforce Committee to help grow the workforce in hepatology. Dr. Ko, welcome to Ask Your Liver Doctors webinar series. Thank you for your support and participation. We are delighted to have you with us and hope to continue our work with you. Again, I want to thank you and Cedars-Sinai for your support over so many years. Would you please start the program, Dr. Ko?
Well, thank you, Farah, and thanks to the Liver Health Foundation for the invitation to speak today on this really important topic. It really is my honor. Let me try to share my slides now. I also want to acknowledge my co-speaker, co-moderator, Dr. Arpan Patel at UCLA, who will be joining us shortly after the prepared lecture in a roundtable discussion about hepatorenal syndrome and liver disease in general. All right, let me see if I can figure this out. Can you see my slides?
We can.
Perfect, great. So the task today is to discuss kidney injury and especially hepatorenal syndrome in patients with cirrhosis. I do receive research support that goes to Cedars-Sinai for clinical trials involving these companies, but none of these trials have any relevance to the topic today. So the outline of the talk, it'll be about 25 minutes of prepared remarks, is to go over the complications of cirrhosis and portal hypertension, define what acute kidney injury is, discuss the causes of acute kidney injury in patients with cirrhosis, specifically hepatorenal syndrome, and discuss the treatment options for hepatorenal syndrome, AKI, otherwise known as HRS-AKI, formerly called type 1 HRS, and then discuss a little bit of general tips about how to prevent kidney injury in patients with cirrhosis. So cirrhosis really is a multi-system disorder. The liver is the organ that is not working very well, but the liver exerts its effects far beyond the liver itself. Patients with cirrhosis can develop complications such as foggy thinking. We call this hepatic encephalopathy. They can develop a stiff heart called cirrhotic cardiomyopathy. They can develop swollen veins, varices in the esophagus and stomach that bleed. They can develop ascites or accumulation of fluid in the abdominal cavity. That fluid can often get infected with bacterial infection. We call that spontaneous bacterial peritonitis. It also affects the lungs, believe it or not. Patients with cirrhosis can develop shunts within the lungs. We call that hepatopulmonary syndrome, or they can also develop elevations in the pulmonary arterial pressure. We call that portal pulmonary hypertension. And then finally, patients with cirrhosis are at unique risk of developing renal insufficiency or acute kidney injury. And the most dreaded form of acute kidney injury in patients with cirrhosis is called hepatorenal syndrome. And we'll get into all the details in the coming slides. There are various ways that we can classify the severity of cirrhosis. In broad terms, we divide patients into two groups. Patients either have compensated or decompensated cirrhosis. If you have compensated cirrhosis, these patients have no symptoms of liver failure, so no variceal bleeding, no encephalopathy, no ascites. If you have any of those symptoms of liver failure, then you are in a higher risk category called decompensated cirrhosis. This is a study that shows the decreased survival rate in patients that have these various complications. So even if you have compensated cirrhosis, if you have varices, that's a higher risk category than patients that have compensated cirrhosis that do not have varices. And then if you have variceal bleeding or ascites, your survival is the worst of any of these categories. Another way to determine the severity of cirrhosis is to calculate something called the MELD score. And those that are familiar with liver disease know what this is all about, but this basically takes 5 blood tests into account. Blood tests that measure both liver and kidney function, and it calculates a score that ranges from 6 to 40. The higher the MELD score, the more severe the liver dysfunction and the higher the risk of death. And as you can see here, a MELD score predicts your chances of dying from your cirrhosis within the next 90 days. Historically, we recommended liver transplant for patients with decompensated cirrhosis or for patients that had MELD scores above 15. At a MELD score above 15, the risk-benefit ratio for liver transplant was in favor of transplant. At MELD scores below 15, in general, the risk of dying from complications of the transplant surgery outweighed the benefit of undergoing the transplant itself. Now, the challenge with our patients with cirrhosis is that the natural history of the disease is quite unpredictable. So I often have patients that are diagnosed with cirrhosis, and their liver function might be fairly well compensated. Their MELD score might be low, say 12. And they'll ask me, what can I expect going forward? Will I need a transplant? What's going to happen to my health? And all I can say is that patients with cirrhosis are at risk for very specific complications, whether it's the ascites or encephalopathy or the variceal bleeding. Despite doing everything right, following all your doctor's advice, taking all your medications, following up in clinic, patients with cirrhosis can get worse. The decline of liver function is quite unpredictable, and it's often punctuated by these acute decompensating events, as shown here. This is an example where a patient might have a MELD score of 12, but then they develop an infection in their acidic fluid, spontaneous bacterial peritonitis. That might raise their MELD score to 25, but you treat the infection, you nurse the patient back to health, and the lab tests improve, and the MELD score might start dropping back to its old baseline. And patients might be stable for another period of time, whether it's weeks, months, or sometimes years, before another decompensating event happens, like in this case, variceal bleeding. And again, in the setting of that stress, the MELD score might rise. You treat the bleed, you nurse the patient back to health, and the MELD score might drop down again. Every time a patient has a complication, it can become harder and harder for the MELD score to return to its old baseline. And so the trend over time is that MELD scores tend to rise in patients with cirrhosis, but it's not a slow and steady rise like an escalator. It's really punctuated by these unpredictable, potentially catastrophic events. Now, what is this physiology that's driving all of these complications, and specifically some attention to the kidney issues in patients with cirrhosis? Well, it all starts with portal hypertension. Patients with cirrhosis have impairment of normal blood flow through the liver because of the fibrosis in the liver. The portal hypertension that develops in the portal vein leads to dilation in the mesenteric venous system. There are various vasodilators, such as nitric oxide, that are produced in the splanchnic vascular bed that lead to vasodilation. This effectively traps blood in the mesenteric circulation, which decreases the amount of blood that's available to circulate systemically. We call that a decrease in the effective arterial circulating volume. When you have a decrease in circulating volume, all of the organs are at risk. When you have decreased blood flow to the kidneys, that activates a series of hormones That causes an upregulation in compensatory systems to combat this decrease in arterial volume. The renin-angiotensin-aldosterone system is upregulated. The sympathetic nervous system is upregulated. The vasopressin system is upregulated. All of these systems conspire to increase renal arterial vasoconstriction, which decreases further blood flow to the kidney, decreases glomerular filtration rate. And that puts patients with advanced cirrhosis at unique risk for acute kidney injury. Many of our patients also are taking medications like diuretics for their ascites, for instance. Overdiuresis puts people at risk for dehydration, which further decreases the effective circulating arterial volume. Medications like NSAIDs, or nonsteroidal anti-inflammatory drugs, lead to worsening of the renal arterial vasoconstriction, again, further decreasing renal perfusion. Patients that require large volume paracentesis to control the ascites are at risk for dehydration or hypovolemia. Patients that are suffering from large volume ascites often have poor appetite, so their PO intake is poor. They might have nausea or vomiting. Again, these all contribute to decreased intravascular circulating volume. Our patients, when they get admitted to hospital, often get CT scans that the contrast agent in the CT scans can hurt the kidneys. Bleeding, variceal bleeding, is a stress on the kidneys as well. Infections also decrease blood pressure, decrease effective circulating volume, and further compromise renal function. So as you can see, this is a perfect storm, a perfect setup for kidney disease in patients with advanced liver disease. Now, there are different societies, kidney societies, that have worked over the last 20 years to refine the definitions of acute kidney injury. And the KDIGO definition of acute kidney injury is the most recent. And acute kidney injury by this group is defined as any of the following: a more than 0.3 milligram per deciliter rise in serum creatinine within 48 hours, or an increase in the serum creatinine equal to or more than 1.5 times the baseline that occurs within the prior 7 days, or a drop in the urine volume to less than 0.5 cc's per kilogram per hour for 6 hours. I think it's the first definition, the rise in the serum creatinine more than 0.3 mg per deciliter, that is used most commonly by hepatologists to define acute kidney injury in cirrhotic patients. The severity of the acute kidney injury is broken up into stages, stage 1, 2, and 3. And again, it really depends on the magnitude of the rise in the serum creatinine. I won't belabor this slide too much. Now, why is this important? You know, if you have acute kidney injury, first of all, acute kidney injury is common. Up to 50% of patients hospitalized with decompensated cirrhosis have episodes of acute kidney injury during their hospitalization. Acute kidney injury is also fairly common in outpatients with cirrhosis, occurring in up to 30% of patients. If you develop acute kidney injury, this affects your survival. 30-day mortality in patients with acute kidney injury is as high as 40%, versus 8% in patients hospitalized with decompensated cirrhosis who do not have acute kidney injury. The 90-day transplant-free survival is also dependent on the severity of acute kidney injury. For milder forms of acute kidney injury, the survival rate is good. Stage 1A has an 84% 90-day transplant-free survival. But if you have more severe stages of AKI, stage 2 or 3, the 90-day transplant-free survival can be as low as 40 to 50%. Now, when we, as hepatologists or nephrologists, see patients with cirrhosis admitted with acute kidney injury, it's important for us to identify the cause. We generally we divide the causes of acute injury into different buckets: pre-renal causes, post-renal causes, or intrinsic kidney disease causes. Pre-renal causes are the most common, things like dehydration or hypovolemia or hepatorenal syndrome. Post-renal is very uncommon. It occurs in less than 1% of patients admitted with AKI and cirrhosis. These are patients with urinary obstruction as the cause for the acute kidney injury. Intrinsic kidney disease is also fairly common. The most common cause is acute tubular necrosis caused by things like contrast agents, medications, or ischemia. Intrinsic kidney disease, such as glomerulonephritis or interstitial nephritis, are less common, but need to be ruled out before we can make the diagnosis of pre-renal kidney disease. These are a couple of figures that show the prevalence of the types of causes of acute kidney injury. Hypovolemia is generally the most common cause of AKI in patients admitted with cirrhosis, followed by hepatorenal syndrome and acute tubular necrosis. The bar graph on the right shows that both hepatorenal syndrome and acute tubular necrosis are more common in patients with more severe stages of acute kidney injury. For instance, on the far right, AKI stage 2 and 3, HRS and ATN are much more common than pre-renal azotemia. Now, what exactly is hepatorenal syndrome? Now, we have a mixed audience. We have doctors, nurses, we have patients, we have family members, caregivers, patient advocates that are the audience here today. And so I thought it would be important to really define this. Hepatorenal syndrome is a severe cause of acute functional kidney injury in patients with decompensated cirrhosis, alcoholic hepatitis, or acute liver failure. By functional kidney injury, I mean that these patients don't have any structural problems in their kidneys. If you biopsy a patient, if you biopsy the kidney in a patient with hepatorenal syndrome, structurally these kidneys look normal. The source of the dysfunction is in the arterial vasoconstriction that occurs in patients with hepatorenal syndrome. Hepatorenal syndrome is characterized by this arterial vasoconstriction that leads to decreased renal perfusion and thus sodium and water retention. Patients with hepatorenal syndrome can have ascites, edema in their legs, decreased urine output, and low blood pressure typically. Hepatorenal syndrome comes in two main forms. We used to call it HRS type 1 and HRS type 2. The new names are HRS AKI, which is the acute type, and HRS NAKI, or non-acute kidney injury type, which is the chronic type. Patients with HRS, whether HRS AKI or HRS NAKI, are at high risk for death. Now, the old definition of HRS type 1 relied on a doubling of the serum creatinine within 2 weeks to a level more than 2.5 mg per deciliter. The new definition, we call HRS AKI, doesn't rely on a absolute creatinine cutoff. Instead, it relies on dynamic changes. So an increase in serum creatinine of 0.3 mg per deciliter or more within 48 hours, or an increase in the creatinine more than 1.5 times from the baseline within 7 days is enough to meet the definition of HRS AKI. To make this definition, this is a diagnosis of exclusion. Patients with HRS AKI have to show a lack of response to volume expansion after diuretics are removed. They have to have cirrhosis with ascites. There cannot be any evidence of shock. There can be no current use or recent use of any nephrotoxic medications. And there could be no evidence of structural kidney disease. For instance, there could be no proteinuria or hematuria on the urinalysis, and the renal ultrasound typically looks normal. The old HRS type 2 was defined as a rise in the serum creatinine to above 1.5 mg per deciliter in patients that did not meet the previous definitions for type 1 HRS. These patients had a gradual rise in their serum creatinine over weeks to months. The new definition of HRS chronic type, HRS non-AKI, really relies on thresholds for estimated GFR. If you have an estimated GFR of less than 60 for less than 3 months, you are called HRS AKD, or acute kidney disease. If you have an eGFR less than 60 for more than 3 months, then this is termed HRS CKD, or chronic kidney disease. Why does it matter if you have HRS 1 or 2, HRS AKI or HRS NAKI? Well, the prognoses are quite different. If you have the chronic type of HRS, we used to call that type 2, the median survival without transplant was 6 months. If you have type 1 HRS, now known as HRS AKI, the median survival was only 2 weeks without liver transplant. So as you can see, this is one of the most dreaded complications that we face in managing patients with cirrhosis. When patients have HRS type 1, this is an ominous development unless they're eligible for liver transplant. This is a typical patient who's at risk for HRS AKI. This is I have dozens of patients that I see like this in my clinic every week. A 64-year-old man with alcohol-associated cirrhosis. He has ascites and he takes furosemide and spironolactone, which are diuretics, to control the ascites. He has a history of encephalopathy that's controlled with taking lactulose. He's admitted for worsening abdominal distension, and he's found to have a bacterial infection in the acidic fluid, SBP. His baseline creatinine is 0.9, but on admission, his creatinine is 1.6. This meets the definition of HRS AKI as long as you rule out other causes of intrinsic renal disease, and there's no improvement with volume expansion and withdrawal of diuretics. His blood pressure is typically low, 95/50. This is the American Gastroenterology Association's algorithm for the management of acute kidney injury in patients with cirrhosis. And I won't take you through all of it, but in essence, if you have more severe stages of acute kidney injury, this is really the time to buckle down. We need to act early. The longer you wait, the more severe the kidney injury progresses, the less likely we are to reverse it, no matter what intervention we offer. We first try to eliminate any obvious causes of hypovolemia, things like diuretics, or we hydrate patients who are dehydrated. If there's resolution of the kidney injury, great. If there's no resolution, then we would consider, if there's no resolution and we've ruled out other causes of acute kidney injury, then this is possibly consistent with hepatorenal syndrome. The next treatment is to use vasoconstrictor therapies with albumin. In the past, our options for vasoconstrictors were quite limited. Our mainstay was midodrine plus octreotide combined with albumin. We also had the option of using a vasopressor, norepinephrine plus albumin. But now we have a new option. The FDA approved the use of terlipressin plus albumin in patients with HRS AKI. And this has been a big development in our field. This was based on 1 European trial and 3 North American trials, which I'll go through shortly. Aside from vasoconstrictors, other options to treat HRS AKI would be renal replacement therapy like dialysis, hemodialysis, or continuous renal replacement therapy, CRRT. Or ultimately, the best treatment would be liver transplantation with or without a kidney transplant, depending on whether or not the patient has underlying chronic kidney disease and the severity of the renal failure. The table below shows some of the various characteristics of the vasoconstrictors. Midodrine octreotide is easy to give. We give that on the floor. It's an oral medication and a subcutaneous injection. Terlipressin, the advantage of terlipressin is that we can also give that on the floor. It's a vasopressor, but we can give it through a peripheral IV. So it avoids the need to transfer a patient to the ICU for norepinephrine, for which we have to deliver through a central line. So although norepinephrine may be a good option, it's much easier to give terlipressin on the floor and avoid having to transfer your patient to the ICU. Now, how does terlipressin compare with midodrine octreotide for type 1 HRS? Well, this is a study that showed that it was superior in reversing HRS. Norepinephrine was compared directly with terlipressin. These are a small number of patients in each of these studies, but it shows similar response rates in terms of reversing HRS type 1. So yes, norepinephrine is an option compared to terlipressin, but it comes with it the need to transfer to the ICU and start administering the drug through a central line. Terlipressin was compared to norepinephrine in a subset of patients with acute on chronic liver failure. These are patients that have underlying cirrhosis, but they suffer an acute injury, whether it's alcoholic hepatitis or viral infection, something that leads to systemic inflammation that often leads to multi-organ failure. Patients that have HRS-AKI in the setting of ACLF seem to have better response rates with terlipressin compared to norepinephrine. Now, what is the evidence for terlipressin? Terlipressin, there were 3 North American trials that were published. The 401 trial was the first trial. The reverse trial was the second trial in 2016. Both of those did not show statistically significant difference in HRS reversal. So the FDA did not approve it. When the patients enrolled in 401 and in reverse were combined, and the 306 patients were analyzed together, there was a statistically significant improvement with terlipressin compared to standard of care in reversing HRS. However, the FDA wanted a larger study, and that was published in 2021, the CONFIRM trial, and it finally showed that there was a significant improvement in HRS reversal with terlipressin compared to standard of care. It's important to note that the FDA did note some safety concerns. In the CONFIRM trial, there was a higher risk of respiratory adverse events, including a higher risk of death from respiratory failure within 90 days in patients that were given terlipressin. There was also a lack of a mortality benefit, but again, none of these 3 trials were powered to study mortality. This is a study from the UK of more than 200 patients with HRS that were treated with vasoconstrictors. The vast majority, 90%, were treated with terlipressin. And I included this to show that the response rates, the reversal of HRS-AKI, was much more likely if you treated it early. If the patients had mild forms of AKI with serum creatinines less than 2.25. As the serum creatinine rises, the likelihood of reversing the HRS-AKI with vasoconstrictor therapy drops off from 80% to 50% to only 14% in the most severe group. So you really have to treat these patients as early as possible. Terlipressin have some caveats. It should not be used in certain populations. Patients that have hypoxia who are going to be at increased risk for developing the pulmonary complications, you should avoid it. Patients with ACLF grade 3, these are the patients with the highest risk of respiratory failure. Patients with severe cardiovascular conditions like MIs or cerebrovascular or ischemic disease like recent strokes, you should avoid. And in patients with serum creatinines already above 5, there's a low likelihood that you're going to reverse the HRS-AKI, and you should think twice before giving it. Finally, patients that are listed for transplant with a high MELD score above 35, these patients are very likely to receive a transplant in the near future you might want to avoid using terlipressin there in case they develop an adverse complication like respiratory failure or ischemia that may make them ineligible for transplant. And to summarize the use of vasoconstrictors for HRS-AKI, terlipressin plus albumin is first-line therapy. Reversal of HRS-AKI is more likely if terlipressin or any vasoconstrictor is started early. You have to be aware of the contraindications for terlipressin, which we went over. Norepinephrine is an acceptable alternative if terlipressin is not available. It has similar efficacy to terlipressin in reversing HRS-AKI. However, the caveat is these are small numbers in these studies, and it requires administration through a central line with monitoring in an ICU. Terlipressin does appear to be more effective in patients with ACLF. Some general tips to avoid kidney injury in patients with cirrhosis. We'd recommend avoiding non-steroidal anti-inflammatory drugs like ibuprofen and ACE inhibitors because these can contribute to the renal arterial vasoconstriction that our patients with advanced cirrhosis already are at risk for. If you have cirrhosis, take your diuretics as directed. Don't self-dose your diuretics. You know, if your ascites is getting worse or your pedal edema is getting worse, don't double up your diuretics. That could be dangerous. That can precipitate hypovolemia, which might tip you over into hepatorenal syndrome. Have your blood test drawn regularly as recommended by your doctor because your hepatologist or gastroenterologist or nephrologist needs to monitor your kidney function. Ideally, you would manage your ascites by focusing on a low sodium diet. It's best to avoid using diuretics at all if you can avoid it. It's important to avoid dehydration. Speak with your doctor right away if you notice symptoms of worsening ascites, worsening leg edema, or if you develop shortness of breath. All right, I think those are the end of my prepared remarks.
It is my pleasure to introduce Dr. Arpan Patel, MD, PhD. Dr. Patel is assistant professor at David Geffen School of Medicine at UCLA, staff hepatologist, West Los Angeles VA Medical Center, investigator for Center for the Study of Healthcare Innovation, Implementation, and Policy at VA Greater Los Angeles Healthcare System. Dr. Patel earned his medical degree from Jefferson Medical College, where he graduated summa cum laude and was awarded membership in Alpha Omega Alpha and the Gold Humanism Honor Society. He went on to complete a traditional training in internal medicine, gastroenterology, primary care research, and transplant hepatology. In 2020, Dr. Patel joined the faculty at the UCLA Vauci and Tamar Manoukian Division of Digestive Disease as an assistant clinical professor of medicine. Dr. Patel's research focuses on ways to improve the quality of life for patients with chronic liver conditions, as well as for their caregivers. Dr. Patel's research has been published in a number of journals, including JAMA, Internal Medicine, Clinical Gastroenterology and Hepatology, Annals of Internal Medicine, Hepatology, Journal of Pain and Symptom Management, and Liver Transplantation. He is an active member of the American Association for the Study of Liver Diseases, and he is also a member of the Liver Health Foundation's Medical Advisory Council. Dr. Patel, welcome to Ask Your Liver Doctors webinar series. We appreciate your participation. Dr. Ko and Dr. Patel, if you allow me, I'm gonna throw out at you the first question and then let you just go through the list of the questions I had received. The question that I wanted to have both of you answer to is, in addition to dialysis, is liver transplant the only solution for people with HRS?
I'm happy to start with that answer. I'm glad that Dr. Ko had a chance to answer a lot of the different management options for hepatorenal syndrome. The way I like to phrase it to patients is that the only way that we could cure hepatorenal syndrome is by doing a liver transplant. And I think I wanted to echo some of what Dr. Cole was saying, is that we do have a lot of other management options. While transplant is preferred, we do have medications like giving albumin, which can increase the patient's hydration, as well as some medications like terlipressin, which are vasoconstrictors to support them. And so there are a lot of different options. I did want to share some of my thoughts on dialysis. So dialysis does not actually treat hepatorenal syndrome. It actually supports a patient's kidneys while we are managing their hepatorenal syndrome and their portal hypertension. So it's a way to support them, but it does not cure their liver disease or their kidney disease. I know actually, Dr. Poe, there are some nuances when it comes to kidney transplant for hepatorenal syndrome. I'd love to actually see if you could comment on that.
You know, I think what Dr. Patel is saying is right. You know, ultimately, if a patient develops hepatorenal syndrome, that just speaks to the severity of the underlying cirrhosis. You know, a lot of times patients are unclear whether they need a liver transplant, right? Maybe their symptoms of liver disease are not that advanced. But when you have life-threatening complication of cirrhosis like hepatorenal syndrome, it becomes very obvious that this patient is at high risk for death. The only way out of this is with a liver transplant, right? Often that's not always possible. Unfortunately, we have some patients that are not eligible for transplant. Maybe they have medical contraindications or other barriers. And so the life-limiting event is their renal failure, their hepatorenal syndrome. And we have to do everything in our power to try to reverse that. Or else, again, as you saw from my slides with type 1 hepatorenal syndrome, the median survival is less than 2 weeks, right? So yes, we always try to offer liver transplant when we are faced with a patient with hepatorenal syndrome, because ultimately, whether the patient reverses their episode of acute kidney injury during that hospitalization or not, the underlying problem is that cirrhotic decompensated liver. And they are at higher risk for having more decompensating events in the future that put them at risk for death. And so if we can offer transplant during that hospitalization, it would be in their best interest. I think to your question, Dr. Patel, about the role of kidney transplant and combined liver kidney transplant. Well, it's important to know that hepatorenal syndrome is a functional cause of renal failure. There's generally nothing structurally wrong with these kidneys. Of course, in the area that we live in with MASH or metabolic fatty liver disease as a very common cause for cirrhosis. We have a lot of patients that already have some underlying chronic kidney disease, from diabetic nephropathy or hypertensive nephropathy. And so, that being said, these patients have a very high chance of recovering their kidney function after they're given a new liver. But the duration of the kidney failure matters. If you're able to offer a liver transplant in a short amount of time, within about 6 weeks, the likelihood that the patient's kidney function will return after liver transplant is quite high. But if the renal failure persists, let's say a patient has HRS-AKI that doesn't respond to our medical management, and to save their life, we have to institute renal replacement therapy as a bridge to transplant. We don't always get a liver right away, unfortunately. We'd love to get that transplant done within those 6 weeks. But if it drags longer than that, let's say they've been on dialysis for 8 weeks, 10 weeks, 12 weeks, at that point, it's unlikely that the kidney function is going to return. And in those patients, we offer combined liver and kidney transplants.
Would we like to go through the rest of some of the questions? I'm happy to.
Yes, maybe we can trade off on reading some of these questions. Do you want to go ahead?
Yeah. So I know there were a lot of questions actually on how to reduce your risk of developing hepatorenal syndrome. You went through quite a few of them, including avoiding medications like NSAIDs and diuretics. I think there were also some questions on, what patients should look out for as signs that their kidney is not working.
Yeah, I did speak to that a little bit. Obviously, in early stages of worsening kidney function, you might not actually feel very much of anything. Many of these patients already have some degree of fluid retention, which is putting them at risk for the further kidney injury. And so if you already have a little bit of ascites at baseline or a little bit of leg edema at baseline, you might not notice too much if the edema starts increasing. But if it's significantly worse than baseline, let's say your legs are double normal size and none of your pants are fitting and you've gained 10 pounds in a week or two, that's a sign that you're retaining a lot more salt and water. That could be a result of a change in your diet. Maybe you're not following the low sodium diet as strictly as you used to. Maybe it's the holidays or you're traveling. Often we see a rise in patients' weight and fluid retention. But if there isn't a change in your diet, if there isn't a change in your doses of your diuretics and you're experiencing worsening fluid retention, I would be concerned. We often see renal failure triggered by infection, and so if you're feeling well and suddenly you get a bad case of influenza or a pneumonia or a urinary tract infection, that could be that trigger that tips the kidney function over into prerenal azotemia, whether it's a dehydration causing AKI or potentially hepatorenal syndrome. So I think if there's any concern about worsening fluid retention, then you talk to your doctor right away. All right, maybe I'll look at our next set of questions here. Let's see. There's a lot of questions about life after liver transplant for those that survive. Specifically, Dr. Patel, can you develop hepatorenal syndrome after liver transplant? Is this something that you're going to be at risk for developing again?
Yeah, that's a good question. The nice thing about the fact that we're putting in a new liver is that we're pretty much reversing the whole pathophysiology of portal hypertension, which causes hepatorenal syndrome. And so when you put in a new liver, you effectively cure it. There are the situation where you could develop kidney problem. You can certainly develop kidney problems after transplant. If you had a pre-existing bad kidney, or if you have other reasons to have kidney disease, like the ones you mentioned, like acute tubular necrosis. But it's very unlikely for them to develop hepatorenal syndrome again if we've taken away their portal hypertension. I think the rare cases that it has happened after liver transplant, it's when someone has developed cirrhosis again or dysfunction of their graft, and then they're developing portal hypertension again and developing kidney failure. But in those cases, those really rare circumstances, we'll think of hepatorenal syndrome, but effectively the transplant is curing their portal hypertension. So they shouldn't worry about developing hepatorenal syndrome, though they can develop kidney disease after for a lot of reasons.
Perfect.
Yeah, and there was another question I saw about life after liver transplant. It was kind of related to just probably things related to life after liver transplant in general. The question was about experiencing brain dysfunction after transplant and whether that could get better. While that might not be directly related to kidney failure, did you want to answer that one?
Sure. Yeah. A lot of our patients have hepatic encephalopathy before transplant. That's a common complication of cirrhosis that leads us to list patients for transplant. In general, that resolves after liver transplant. But in patients that have very severe encephalopathy, refractory encephalopathy, very difficult to treat encephalopathy, those patients are at higher risk of noting that their encephalopathy doesn't totally clear. They might not have periods of overt disorientation, but they'll complain of a brain fog. You know, that's like the usual way that it's described. It's just like I'm like their brain is just working a little bit slower, you know. And I do see that more in patients that were sicker going into transplant, so they had higher MELD scores. Yeah, maybe they spent some time in the intensive care unit, and they might have been unstable on various forms of life support like vasopressors. They are at higher risk of developing persistent brain fog post-transplant. But I wouldn't say it's that common. And for most patients, that also improves over time. So I wouldn't be afraid of transplant because of a concern for persistent encephalopathy. It's a good question. I was going to pose a question that wasn't entered in, and just curious about what your take on this is. That you know, the treatment of HRS-AKI in transplant candidates is a little controversial. And one of the controversies stems from what we talked about before, which is that by reversing the HRS-AKI pharmacologically, it doesn't improve their long-term survival, right? It improves their short-term survival. They're not going to die of kidney failure. But ultimately, they're still left with decompensated cirrhosis and are at risk for death. In some ways, reversing their HRS-AKI may disadvantage them because their kidney function improves and their MELD score drops and their priority on the wait list declines. What are your thoughts about that? Is it something that you would think about, and it would discourage you from using these medications to reverse HRS-AKI?
Yeah, that's a really good point. I think that specific, when we come to real life, we're faced with so many different sets of challenges that we don't see in randomized controlled trials. And I think the first thing I sort of think about is whether this patient is listed for transplant. Actually, a lot of times when we see these patients for the first time, they may have never seen a liver transplant doctor. They may have not even known that they had liver disease. They may not even be listed for liver transplant. So you know, in many ways, we have only a tincture of time to make a decision. So for the ones who haven't been listed for liver transplant or haven't been considered before, I tend to pull the trigger quite early, because there's always a lot of uncertainty sometimes over whether people can get listed or not. And in most cases, if we are extending some support to them and providing them some time, even if that means more time to do a liver transplant evaluation, I think that does make sense to initiate the treatment. It gets a lot more complicated when people are listed for liver transplant. And I think that from the handful of cases that we've now had, you know, with this new treatment, a lot of it is just providing a lot of open honesty to the families that this could happen too. We also know that while terlipressin has provided us, our patients, a lot more time and has had some benefit, we know terlipressin is associated with risks also, like you mentioned, particularly for those who develop volume overload or develop worsening liver injury. So the situations that I've dealt with this in is that I have used it, but I have a very low threshold to stop it if I'm noticing any complications from terlipressin. Unfortunately, the truth of the matter is, to what you mentioned, is that when that creatinine number goes down, the MELD score goes down, and then become a little bit further away from transplant. But in general, and the other thing I would just say is that a lot of these decisions sometimes are made by a group of us at transplant centers who weigh the risks and benefits. So I think that it always makes sense to get more people involved and just to be as open and transparent to families as possible that this could happen.
Absolutely. These are really complicated decisions.
How long is if you do a double kidney liver transplant, how long is that surgery, and how many teams of doctors are going to be there in the operating room?
That's a great question. You know, it seems overwhelming, right? To tell a patient, you know, they already are stressed that they need a liver transplant. Now you're saying you might need a liver and a kidney too. The reality is it doesn't actually add that much time or risk. In patients that are undergoing combined liver kidney versus liver alone, The risk is really in the liver transplant. That is the more high risk of those two surgeries. For the kidney surgeon to implant the kidney, it's a very straightforward operation. They usually do it in less than 30, 40 minutes. But that's after the liver has been sewn in and is working, then they would start working on the kidney. Sometimes they don't even do the kidney transplant until the next day, for instance. So I try to emphasize to patients and families not to stress if they need a combined liver and kidney. It's really incremental risk that's added to their surgery.
I have one question I'd like to ask, and it's about this idea that it's a liver problem and a kidney problem, and there's a liver specialist and there's also a kidney specialist. So want to ask you, how do you explain to patients kind of what one person's role is, the other person's role, who's sort of making decisions? Because I'm sure it could be pretty confusing.
Yeah, that's part of the fun, I think, of working in this field as a transplant pathologist is that, we work in teams. None of us do any of this alone. We work with surgeons and nephrologists and cardiologists and infectious disease and pharmacy. And so that's made clear to patients very early on. It's really a team medicine approach. I think every medical center might do things a little bit differently about who decides, about what in different scenarios. We work pretty well together with our nephrologist. There's a lot of transparency. We use common protocols, and so there's not a lot of dissension or disagreement in terms of management decisions. So I think that helps with patients where they're hearing the same thing from multiple specialists, or else they might feel a little bit nervous, like, is this really the right thing to do? If, for instance, a nephrologist says, I don't think this is HRS-AKI, we don't need to start a vasoconstrictor, but the hepatologist does. It's good to be on the same page before you're approaching families, and we try to do that.
Yeah, I always feel like there's so much teamwork in hepatology, and it's always nice for families to hear the same information twice, maybe even more than twice, when it comes to their kidneys and their liver. So yeah, I definitely agree with that.
One thing I wanted to bring up from the questions. Oh, sorry, Farah, go ahead.
No, go ahead, please.
One of the questions was about, what in general about how patients can keep their kidneys healthy, avoid developing hepatorenal syndrome, specifically medications, what medications they have to look out for. And, I did mention a few like the NSAIDs and ACE inhibitors. But a clinical scenario that's very common in my practice is what to do with chronic pain. And so in patients with cirrhosis, they've already got it in their heads through different channels to avoid Tylenol. And now we're telling them they can't take NSAIDs too for their arthritis or their, headaches or whatnot. How do you manage that, Dr. Patel?
Yeah, I think that's a really great question, and really common situation, I would say, particularly because even if a lot of patients are having ascites and developing pain, even if they're getting paracentesis, they still have a lot of pain in their musculoskeletal system and in their abdomen. I would say that the first thing is for sure do no harm. I think one of the most common pain medications that we do use is NSAIDs, and particularly in patients who have kidney disease and liver disease, it's really a no, always, in terms of using NSAIDs. I will say that some room we do have in cases is a little bit of very little room with Tylenol. We could have patients take technically up to 1.5 to 2 grams of Tylenol, 2,000 milligrams. We tend to undershoot so that they don't take more. It is technically an option. I will say that I've been spending a lot more time trying to explore the mechanism of pain, because a lot of times if pain is in the abdomen, we could always do, a paracentesis, we can always use abdominal binders. The degree to which we can try to get to the root cause of the pain matters a lot. I have been using a little bit more solutions, like topical lidocaine patches, if people are experiencing pain. A lot of times, I've sent some patients to pain management doctors and integrative medicine doctors too, if patient prefers, for instance, and have done things like acupuncture. I think that everything that a patient does do should go through their hepatologist and their nephrologist, just to make sure that they're going through all of the right procedures for understanding the risks and benefits. One question we do get asked a lot is whether patients can be on opiate medications. That's a common, medication that people sometimes use for a lot of different reasons. The caution we have about using opiates is that it could increase a patient's risk of brain fog or hepatic encephalopathy. And it can also create constipation, which can make it hard to treat hepatic encephalopathy. And so the instinct that we always have is to avoid them. And I think that in most cases, it's probably a good idea to avoid them. I think that in some rare situations where pain is difficult to treat for a lot of different reasons, it's again a very important, transparent conversation that the patient should have with their doctor about the benefits and risks of being on opiate treatment. Some of them can be better tolerated than others, depending on if someone's liver or kidney function is intact. So it's never a never for me when I talk to patients about it, but it should be avoided in many cases when they have both liver and kidney failure or they have hepatic encephalopathy. But it's very challenging to treat. And I think that's an area that we should be doing a lot more research in.
Unmet need for sure.
Yeah. Farah, did you have a question from before?
No, but one of the things that this is such a life-threatening disease, but we don't hear about it much, maybe because it's a rare disease. Why don't we hear about it more? Because the life expectancy after you have it, it's so little. And if you don't get the right kidney and the right liver and do the transplant on time, then the patient is lost. Why aren't there more research and more noise about this?
Maybe I can take that. I think part of it is because this is really a condition that's diagnosed in the hospital. You're not diagnosing hepatorenal syndrome in the clinic with your primary care doctor. This is so severe that it needs hospitalization and the management of a multidisciplinary transplant team. Where transplant really is first and foremost needs to be their candidacy needs to be determined, and then all the other decisions sort of flow from that. So, with cirrhosis, there are so many complications that come up. Hepatologists, we tend to focus on the common ones that patients are likely to experience at home, in the outpatient setting. But this type of a severe acute decompensation, it really is. It's kind of behind the screen a little bit because it's on the inpatient side. Is my impression.
Yeah, I think that's a huge part of it. I'll just echo what Dr. Kuo said, and I think that because it's always sometimes so more commonly in the inpatient setting, a lot of times there should be a lot more education, I think, to a lot of different people in the medical community treating these patients or treating them outside of the inpatient setting. I think with these new medication, terlipressin, and venues like these, we could be educating a broader set of health professionals who could be looking out for it. We wish that there were situations where a patient could go to their primary care doctor and talk about hepatorenal syndrome, but the way that it operates currently is that hepatologists and nephrologists who are treating these patients, particularly at a transplant center, are the ones that have the most specialized knowledge. So I think this is an opportunity to have broader engagement with a lot more health professionals treating these patients. But for the reasons Dr. Kuo said, I think it tends to be more specialized knowledge, even though it's something that's so critically important for patients and families to know about.
I want to thank Dr. Kuo for a wonderful presentation. Thank you, Dr. Patel. As I mentioned, we will be doing a lot more this year on the impact of drugs as well as alcohol and on our livers. So we will be coming back to you soon for more information. And I know one of the things you work on, Dr. Patel, is pain management. So maybe we should do a webinar on that. So thank you, Malencrot, for your support as well. And I just want to remind everybody that we are hosting Walk for Your Liver Orange County on Saturday, May 4th at William R. Mason Regional Park in Irvine. In honor of what people say, May the 4th be with you, we have adopted the Star Wars theme for this event. Please register to walk with us. You can get more information by visiting our website. And the other information is we are hosting a presentation on March 14, and that will be on drugs and alcohol. Maybe it will be mostly on alcoholic hepatitis. We are still working with our presenters trying to narrow down the subject to a point that we can actually attack it in one session. And the other thing I need to say is that please don't forget, we are on all social media. Please join us and see us. We'd love for you to like us and make comments on our website or on our social media. We are always there alive and doing things. And to our audience, thank you so much. I'm so sorry a lot of them couldn't be here, but we will do more. And be well. Thank you, Dr. Patel. Thank you, Dr. Cole. Thank you, Malencrot. We will see you. Let me see. I have a hand that's raised, but I don't know who that audience is. Can you type in your? Is there a question you have?
Hi. Yes. Let me type in. Sorry.
Okay, or you can ask.
I
if
gave you permission, yeah, so you should be able to
Okay.
ask
Yeah,
out
Thank
loud.
you.
please.
By the way, good evening, guys. I'm sorry. I just have a quick question to ask for to the doctors, and I really appreciate it. I just want to ask a quick scenario. I want to ask if you have a patient who looks like that they have hepatorenal syndrome, but they have a systolic blood pressure of 130, 140s, or mean arterial pressure of 75 or 80s. Do you eliminate them from your differentials?
It makes it much less likely, because I'm not sure who I'm speaking to sounds like someone from a health professional background, but it because of hepatorenal syndrome usually happens in a vasodilated state, we usually expect a low blood pressure. I think common situations where we do see hepatorenal syndrome is when someone has really difficult to treat or refractory ascites and they have low blood pressures, and we often get situations when they don't have those two things and people think they may have hepatorenal syndrome. So I think you're right on in your assessment that when people tend to have higher blood pressures, it tends to make it less likely that they have hepatorenal syndrome. But I think that kidney injury in these patients is really complicated. You can always have many different causes of kidney injury at once. So I think that it's always best to just speak to both the hepatologist and nephrologist in that case, but that's a good assessment in general. I don't know if you have anything else to add, Dr. Flo.
No, that's a clinical pearl that I give my fellows. I'm very skeptical of the diagnosis of HRS in somebody that's normotensive, and especially if they're hypertensive, for sure.
I think you're muted, Farah.
Do you have a follow-up to question, or are you good to go?
I do have one more question, if I may ask. And I'm sorry if I'm asking too many questions. I'm learning. I'm really interested in this topic, and I would like to know more about it. So, and I really have another scenario. Like if you have since patient with ascites, they usually are like, they have more fluid in their body. So your type of choice of diuretics that you're going to be using, like, what are your takeaway points using spironolactone for these patients? Are you more on the loop diuretics or the spironolactone?
Yeah, maybe I could take a stab at this. We like to use the combination. The loop diuretic is really promoting natriuresis and some aquaresis, but the side effect is it can cause hypokalemia, whereas the spironolactone, the side effect is it can cause hyperkalemia. So often, if you get the ratios right, you can balance the potassium levels, and you don't have to give potassium supplements, for instance, if you're using furosemide alone. So we often use the combination of furosemide plus spironolactone. But you can also use other diuretics. Our cardiology colleagues, often use things like, Bumex or metolazone, and those are okay too. I think in hepatology, we have a little bit less experience with those drugs, and we tend to fear what we have less experience with. And they tend to be a bit stronger than furosemide, and so we worry a little bit more about overdiuresis. Whereas we've been using the combination of furosemide and spironolactone for so many decades that we have, we're quite comfortable about what to expect with these doses.
Yeah, I think the only thing I'll add is that we tend to monitor patients pretty regularly when they're on those medications for reasons we talked about, like if they get sick or if they start to develop hepatorenal syndrome. So we always make sure to monitor their sodium and renal function pretty closely while they're on those medications.
Thank you so much. I am going to say that this is the end of our program. Thank you again, Dr. Ko, Dr. Patel. And as soon as our video is ready, we'll post it on our website as well as on our YouTube channel. And hopefully we'll do this again this year, one more time, because something glitch went down. But in any case, it was a great presentation. I personally learned a lot. And I'm sure that everybody who will watch this video will learn a lot also. So thank you and be well, and we'll see you March 14th. Thank you.